Thanks very much. So I'm glad you said doing better, because I think allergy is something that our institution, our hospital here in Brisbane doesn't necessarily do very well, but we are doing better. And we've certainly been inspired, I think, in recent years by some of the work that's been going on, particularly down in Melbourne by Jason Tribbiano and that group. And I will touch largely today on some of that work. So I'm going to go through a short case, set the scene. We'll talk about the nature of the problem in principle and the local practice. And again, we'll focus on some of that research that's happening in Melbourne. And then I'll discuss some strategies to overcome this problem. Education, antibiotic allergy review and delabelling, which is now a phrase being used more often. I'll touch on desensitisation, but not very much, and finish with collaboration efforts. So, quick case. So this is one of our patients, a 23-year-old lady who had a horrible hollow visceral myopathy disease together with lupus, and she had very poor GI function and TPN dependent, difficult IV access. She had a venous fistula with recurrent infections, and importantly her antibiotic allergy labels were as follows. So meropenem anaphylaxis with a question mark. A couple of years ago that was listed, and vancomycin, query rash, query red man syndrome. So probably a couple of things you might see not uncommonly in your own practice. And her presenting complaint this time was of new episode of line sepsis, and she was hypertensive and febrile, quite unwell, and she was empirically given gentamicin, vancomycin, and obviously fluid resuscitation. Blood cultures came back in 3 sets, and as you can see there, she grew a ESBL Klebsiella, which is rather nasty, and the requirement then was to give her 2 to 4 weeks of IV antibiotics, which presented us with a problem. We didn't really want to give her gentamicin for that period of time. If we could avoid it due to obvious toxicity reasons and also potentially efficacy reasons. And we couldn't really get source control of her graft. So ideally she really would like a course of meropenem to avoid those long-term aminoglycosides. She wasn't suitable for a graded meropenem challenge. She was determined to be sort of hemodynamically unstable at that point. So we performed a rapid IV meropenem descent on her, which went ahead without complications, and she completed 4 weeks of therapy successfully. And then she was marked as a future candidate for skin testing with or without a graded challenge of meropenem to try and really clarify that allergy. So that really sort of highlights some of the issues we face day to day in infectious diseases when it comes to antibiotic allergy labelling and the consequences that has on our choices of antibiotics. So we all know that labelling of allergy to antibiotics is very frequent amongst hospital inpatients and patients in general, and penicillin allergy most commonly is reported in as common as 5 to 10% of hospitalised patients, depending on which case series you're looking at. And it's estimated that well under 1% of those patients have a true hypersensitivity, and that's based on skin testing methodology, which is quite robust. That's with regard to penicillin. Bactrim and sulfur allergy is reported up to 5% as well. Again, very useful drug for us. And histories of drug allergy are really important, but very difficult, problematic to access and problematic to interpret due to people being poor historians and even us healthcare workers being very poor at documenting these things. So most reactions are fairly mild when it comes to antibiotic allergies. However, obviously we know that some are critical and life-threatening, which poses a great problem. Also, cross-reactivity is an issue, as is multiple allergy, which can exist in one patient. And that problem patient we all know has multiple hypersensitivities, multiple comorbidities. They're coming into hospital frequently, and they're frequently getting infections. We know that allergy, it takes important antibiotics off the table as options. And alternative antibiotics, as we've seen in that case, can be problematic, whether it's unnecessarily broad spectrum, toxicity, or cost. And beta-lactams, they're our workhorse antibiotics, as we all know. They're highly desirable for a range of infections, whether it be staph sepsis, enterococcal infections, or even syphilis. We want to preserve them whenever we can and be able to use them. We don't want allergy to stand in the way. And increasingly we have fewer options to begin with when we go to choose antibiotics due to a slowed antibiotic pipeline, perhaps even supply chain issues that we could experience from time to time, and emerging antimicrobial resistance. Obviously we've heard a lot about that this morning already. So just to touch on what we know, locally here in Australia, I might skip the entree and go straight to the main course here, which is from the NAPS dataset. So this is an analysis that was done by Jason's group down in Melbourne looking at all the NAPS data from 2013-14, which is quite a large number of patients, as you can see, 21,000 odd, who received antibiotics. And from that group, we know that 18% of them had an antibiotic allergy label. And that varied in prevalence across hospitals and within hospitals across different inpatient units, as you might expect. And that was associated with, importantly, increased use of broad-spectrum antibiotics and higher rates of inappropriate prescribing. As you can see here, so patients with an antibiotic allergy label were far less likely to receive appropriate beta-lactams, penicillins, and even glycopeptides. And here's the data in graphical form as well. So what you can see here is, if you compare the two groups, the antibiotic allergy labelled patients are in the dark bars, so far less penicillins, no real change in cephalosporin use, interestingly, but an increased trend to use glycopeptides, fluoroquinolones, sulfur antibiotics, and a variety of others. So not exactly rocket science, we would expect this, but it's good to see the data demonstrated at such a large scale. So how can we think about strategies to overcome this problem of allergy labelling and antibiotic allergy, whether it's true or false in a patient? So education obviously is very important. So raising awareness for both patients in their understanding of antibiotic allergies and labels, but also healthcare workers across the board, whether that's medical, nursing, or pharmacy staff. So people need to be upskilled in terms of, appropriate allergy classification, appreciating the issues around cross-reactivity, providing accurate and clear documentation, and importantly communicating with patients as well about the true nature of patients' allergies, and also referring patients to appropriate services where they are available, so they can have their allergy clarified, if indeed delabelled. And healthcare workers also need to understand and appreciate the safety and utility of testing and re-challenging, and that's been borne out in a number of surveys internationally when people have been asked about their opinions on those strategies. Sorry, in that photo there is just Jason Tribbiani's group. They're just making its way into the ABC News in Victoria, highlighting the fact that there's a clinic here. We can help clarify people's allergies, put important antibiotics back on the table. So it's great to see that getting a greater public light. So I'm going to focus now on just the antibiotic allergy assessment and indeed delabelling pathways. So what is this? So it's a thorough allergy assessment is the ideal scenario here. So that incorporates multiple techniques. So obviously a very thorough review of the allergy history, whatever might be available to you, and we know that can be difficult. And then really importantly, hypersensitivity testing. So that's a combination of the following, skin prick testing, intradermal testing, and perhaps for delayed type hypersensitivity reactions, we can also do patch testing, depending on where you are and what's available to you at your clinics. Then also combined with that, we like to consider doing a controlled oral or perhaps even indeed parenteral challenge, usually for inpatients, that is the parenteral. And then following that, we need to analyse those results and then clarify the allergy status for the patient, whether it's in the positive or the negative for a number of agents. Then we can seek to establish a safe therapeutic pathway for that patient in the future. So really clearly outline to the patient what they should and should not be exposed to down the track, or indeed if they need to have something, that they need to be desensitised to that agent. And then really importantly, documenting that and sharing that with other healthcare providers who manage that patient, which again is something we don't do very well, I don't think, as a whole. This is a pathway that, again, Jason's group published some years ago now, that just kind of highlights their approach. So we have a patient identified here with a label. If there's a sense of urgency, we progress to desensitisation and giving them that particular drug. If not, we can refer them to an allergy specialty service, whether that's an inpatient or an outpatient service. For example, in the setting of a IgE-mediated reaction here, we would look at skin prick testing, followed by intradermal testing. Depending on the results of those, obviously if they're negative, then we could then progress to an oral challenge, with amoxicillin in this case, if it was penicillin. And then, depending on that result, we would look at labelling the patient non-allergic or allergic, and then giving appropriate advice about whether they need desensitisation or alternative antibiotics. And obviously there's a number of other pathways there depending on the nature of the patient's problem. So how should this be done? How should the assessing and testing be done? Who should do it? This is a common question. So should it be an immunologist or allergist? And I would argue they're obviously well placed because they're highly skilled in allergy assessment. But importantly, they may lack the suitable understanding around antibiotic options. What about an ID physician? Well, they're highly skilled with antibiotic options. They may not be, or they won't be as skilled as an immunologist in terms of allergy assessment. I think a good example of this that's already occurred in practice is anaesthetists. So anaesthetists in many hospitals run their own allergy skin testing services. And they do that not because they're necessarily the best people to assess allergy, although they're very good, but they are definitely the best people to assess the different options that might then be useful for the patient, depending on the allergy testing results. So the anaesthetists at our hospital run a clinic, but they run that in collaboration with and close contact with the immunologists. So ideally it's a combination of both practitioners. And how do you identify your patients? How do you set this up? So do you receive referrals from immunology for the antibiotic allergies that they're getting? Or do you have it integrated into your AMS program, which is what many people now are striving to do? So trying to get referrals from their inpatient or outpatient teams through the AMS service, maybe identified through a routine consult or an audit round, or indeed more and more nowadays identified through electronic health records and reports to try and proactively find these patients. What about hospitals with limited resources who don't have access to well-built AMS programs, or indeed EHRs, or specialists in the area of immunology, or ID for that matter? How should they progress and try and adopt some of these principles? Who do you target? Which patients are you going to go for? Are you going to screen the whole? Are you going to go for the whole hospital? Everyone who's listed for any allergy? Probably not. Probably not worth your time. I'd argue you should pick off the high risk and the high yield patients. So the high risk patients are those with multiple allergy labels where they've got very limited antibiotic options left on the table. Try and clarify those for them, widen up their options. And then the high yield patients. So those patients that may not have as many allergy labels but are highly likely to receive antibiotic therapy in the near future. So these are the key patient groups that, say, we will be looking at our hospital. So oncology, haematology, solid organ transplants, chronic respiratory disease patients, end-stage renal failure patients, and obviously any other really frequent flyers that present with these labels. And again, this is a suggested model from Jason's group on how you might structure a service of sorts. So picking up the fact that a patient has allergy alerts, then referring them to an assessment for that, whether that's inpatient or outpatient, and then based on the result, and then using that testing algorithm that I already showed you, and then based on the results of that, defining the action that should be taken and clarifying through documentation what is now true for that patient. Just to move on to outcomes, so you can set up a service and that's great, and you identify patients and you might delabel them. But what does that result in? And I think really importantly here, this work's been done now in Melbourne with Jason's group. So they have assessed the impact of integrating a allergy testing program within the AMS service at both the Austin and the Peter Mac. And that involved weekly clinical consultations and testing. And that was a multidisciplinary approach. And they looked at a 14-month duration across 2015-16, identified 118 patients, and they described their baseline allergy labelling details, the outcomes of their testing and delabelling, and then really importantly the impact on the antibiotic usage that had occurred, comparing to 3 and even 12 months prior to 3 months post assessment and delabelling. So here's what they did. They screened 141 patients. They ended up with 118. And of those patients, 83% had some sort of delabelling occur after they were assessed. And indeed, 56% of them had all of their antibiotic allergy labels removed. And not surprisingly, this is the breakdown of what labels were there. So penicillin being the highest, followed by cephalosporins, sulfur antibiotics, glycopeptides, etc. Penicillin being by far the largest, which is great because the methodology we have for skin testing and intradermal testing for penicillin is very robust, so that's very useful. I found this interesting. Importantly, where do they get their referrals from? Was it just the AMS team picking these people up? Well, no. I mean, they picked up a chunk of them for sure, but they came from far and wide. So pharmacists, the ADR committee, which is a really important point. What happens with those ADR reports that go through to those kind of committees. How do they get acted upon? This could be a very useful way of closing that loop. And other specialists here, haematologists, transplant folk, and again, allergists referring back to a ID physician-run clinic, which is great. And even patients being referred from outside of their hospital, so not just from within the tertiary hospital, but from primary care as well. So I think a very well advertised service, clearly, and very well accepted within those two hospitals. And these are the results in terms of the change and the impact on antimicrobial usage. So what you can see here, pre and post, as you would expect, penicillin use goes up. Beta-lactam, beta-lactamase inhibitor use goes up. Cephalosporin use goes up also. And then what's going down? We're having an impact on reducing carbapenem use, fluoroquinolone use, glucosamide use, glycopeptide use. So this looks very favourable indeed. I'm very glad this got published. So what they showed was this at 3 and 12 months using an adjusted odds ratio. Significant impact on narrow spectrum penicillin, narrow spectrum beta-lactam, bli-blis, and also a decrease in the use of restricted antibiotics, which covers those other groups that are on that graph. And they also looked at appropriateness across the board with prescribing, and they did a multivariate logistic regression and showed that they had an adjusted odds ratio of 15.23, an improvement in appropriateness over that period. So I think that's very useful as well to know. So just to finish off with desensitisation, which is kind of one of the last strategies you want to do. Obviously, you want to be trying to avoid this if you can assess patients up front and delabel them. But if you have to do this, you have to do it. So the goal here is to convert a drug allergic patient from a highly sensitive state to a drug tolerant state temporarily. And used primarily for IgE mediated hypersensitivities, although we can do it for selective delayed type hypersensitivities, and it's effective for many antimicrobial classes. There's no doubt about that. It does work. So the candidates for this, as mentioned, it's IgE mediated with this, the mild type 4 reactions. So maculopapular rash is typically, you want to avoid the more severe reactions like Stevens-Johnson's and other sort of scar sort of scenarios. Patients with a positive skin test or a negative skin test that have failed an oral challenge, the candidates, and they've got to be hemodynamically stable in case something goes wrong. And there needs to be an urgent need for that desired antimicrobial. Otherwise, we try and run them through skin testing and challenging. And they must importantly be able to maintain dosing after desensitisation has occurred, whether that's as an inpatient or an outpatient. How do we do it? Well, we just carefully introduce the antigen very slowly, starting at a very dilute dose, usually 1 in 100,000, and then rapidly up titrate that every 15 minutes or so. A little bit slower maybe for the non-IgE mediated reactions like the maculopapular rashes. Do doubling increments until we hit a therapeutic dose, and then maintain on therapeutic dose to maintain tolerance. But really importantly here, we don't clarify the allergy label for these patients when we do this, and we go through a lot of effort here to get an urgent outcome, to get people on therapeutic doses, but we're none the wiser as to whether that was actually worthwhile doing in the first place. And just lastly, collaboration. So obviously when we're looking at allergy assessment and testing and even desensitisation, this all really should involve a multidisciplinary approach, whether it's designing your procedures, reviewing, planning, undertaking the actual testing, the delabeling or the desensitisations, and then importantly evaluating what problems you're having with the processes and refining those as a team. And that team, I think, should clearly involve an immunologist, an ID physician, a pharmacist and a clinical nurse, if you have access to those 4 people. So in summary, antibiotic allergy labelling remains a considerable challenge for appropriate antimicrobial prescribing. Education, delabeling and desensitisation strategies are all key components of the solution. Targeted patient selection is likely to provide the most value for investment, especially where resources are limited. And that multidisciplinary team-based approach is likely to provide the safest and most effective pathway to success.